Um, he probably wins the award of the person that's been featured on our platform the most times. It's Howard Gleckman, because whenever there is a issue that relates to public policy or what's going on in government related to older adults, Howard is deep into these topics. And I'll tell you how and I'll drop into chat. He did a wonderful discussion with us right at the beginning of the year on aging in the age of Trump. But um, what led me to reach out to Howard, and I'm delighted that he agreed to come back on, was I'm on an Aging Life Care Association listserv with all the aging life care managers. And a bunch of questions came up related to Medicare and Medicaid changes from the aging life care managers. And if the aging life care managers don't have a good handle of what's going on, then we know this is a big topic of discussion. I shared a little bit of that thread with Howard, and I said, Howard, would you come on again? Because I think you could help by sharing your insights with our community. So, Howard, thanks again for coming on with us today.
Steve, it's a pleasure. Always good to be with you. And you're right. There's the big, beautiful bill is big, confusing bill, and there's a lot of uncertainty about it, and I'm happy to help you out.
Excellent. Now, before we dive into that, Howard, there's probably a handful of folks on this call today that have never met you before. Give us a brief overview of your background and what led to your passion in this area.
Sure. So I suspect, like many people on this call, my passion in this area came about from a personal experience. I was a journalist for many years and writing about economic policy and writing a little bit about healthcare. And one day the phone rang and it was my father-in-law calling from Florida telling me that my mother-in-law had just died suddenly. We went to Florida. My wife and I went to Florida, realized that she had died because she was caring for him. He had very bad cancer. They never told anybody in the family about how sick he was, and he couldn't take care of himself. So we needed to figure out what to do. A few months after that, my dad got sick. We had to take care of him, had to figure out what to do. And I realized just how chaotic and dysfunctional the system of long-term care is. I got a fellowship from the Kaiser Family Foundation, then called the Kaiser Family Foundation, to write a book about this called Caring for Our Parents. I never went back to Business Week. Instead, I took a job at the Urban Institute, where I'm a senior fellow and I write about and research tax policy and aging policy issues. I really spend a lot of my time just focused on all these issues around aging. I do a column for Forbes.com on aging policy as well. So it gives me a chance to really keep up with all of what's happening here. And bottom line is enormous number of changes. Uh, a few of them for the better, most of them not. And I'm happy to just spend a little bit of time talking to you about what's happening.
I love it. And folks, I'm gonna drop Howard's contact info, the websites where you can learn more about what he's doing. He writes a column on Forbes. I'm gonna drop that in there. And the format that works really well with Howard, and we agree to this, is that he sort of does a brain dump on us. A 20-minute ish monologue on what he's seeing out there. And then we'll do our best to respond to all your questions, many of which have actually come before we even started this discussion today. And so, Howard, if that sounds good to you, then I say let it rip, and then I'll either jump on if there's a urgent thing, but when you wrap it up, then we'll start hitting all the questions.
Sounds good. So I'll just run through really quickly Medicaid, Medicare, and some of the other issues that have come up over the last few months. As Steve mentioned, the last time I was on, I didn't remember, it was so long ago, but the last time I was on, all we could do really was kind of speculate about what was going to happen with the change of government. Now we know a lot more. I still have to say, in all honesty, there's still a lot of unanswered questions, but we know a lot more than we did. So let me just jump right into it and first start talking about Medicaid. Uh, I think most of you know this, but to set the stage, there are about 7.2 million seniors and about 4.8 million younger people with disabilities who are on both Medicaid and Medicare. These are the so-called dual eligibles. Even though they're a relatively small fraction of the Medicaid population, more than half of Medicaid dollars are spent on people with disabilities and older adults. And of course, the other thing to keep in mind as we go through some of the changes is that while Medicaid is run by the states, about 70% of its funding comes from the federal government. So the big budget bill that Congress passed last month would cut Medicaid spending over the next decade by about $1 trillion. That's trillion with a T. About a third of that, about $336 billion, would come from requiring states to impose work requirements on its recipients. About 60 billion would come from increased paperwork that the recipients are going to face. And about $120 billion is going to come from changes in so-called provider taxes, which effectively reduces the federal contribution to the program. So let's start with the work requirements. Um, First thing to keep in mind is older adults and young people with disabilities generally are exempt from the work requirements. So nobody's going to make an 80-year-old widow with dementia go to work. That's not what this law does. The problem is what happens with family caregivers. And the law is so vaguely written that the answer is we don't really know for sure. So what the Congress did was instead of trying to define what caregivers were exempt from the work requirement, instead it took a definition that was from an old law called the RAISE Act, which was really intended to better coordinate federal agency support for older adults and for family caregivers. It was never written to determine who could get benefits and who couldn't. Uh, but Congress took it anyway. They stuck it in the bill. And now we don't know what's going to happen here. The risk is imagine a low-income person who has to give up their job to care for a loved one. They could lose their own Medicaid benefits. The other problem is that many people who actually would be eligible for Medicaid benefits, even because they give up a job to care for a loved one, might lose those benefits simply because they can't comply with the paperwork requirements. The law requires, the current law requires that you recertify once a year for Medicaid enrollment. The new law says you have to recertify at least twice a year, and states can make you recertify even more frequently than that. Um, the good news is that these work requirements are not going to take effect until December of 2026, which just happens to be a month after the next congressional elections. States could do it sooner, or they could actually ask the federal government to delay the work requirement until as long as 2028, but generally figure that these are going to take effect in December of 2026. Now, let me switch gears a little bit and talk about the cuts in the federal contribution to Medicaid. So one of the things it does is it limits the ability of states to impose taxes on Medicaid providers, such as nursing homes and hospitals. If anybody really wants to know how that works, I'll try to answer it later, but it's a long, complicated story. Bottom line is less federal contribution to state Medicaid programs. Uh, Again, the thing to keep in mind about this provider tax limitation doesn't begin to even take effect until 2028. So there's plenty of time for advocates and others to try to get this changed. And there are actually a number of Republicans who voted for the bill who actually now say, well, maybe we're having second thoughts and maybe we want to change it. So that provider tax thing may actually get changed before it ever takes effect. We'll see. But if it doesn't, it's going to have a significant effect. It's going to mean $300 billion dollars or more of federal dollars are going to get cut from Medicaid programs, and states are going to have to make up that money somewhere. There are other changes as well that limit federal contributions. The big one is states that expanded their Medicaid under the Affordable Care Act, under Obamacare. These are the so-called expansion states, got extra money from the states to run their Medicaid, from the feds to run their Medicaid program. That money is going to go away on January 1st, much sooner than the other things. So this leaves states with a real choice. They can either cut benefits, they can limit eligibility, or they can raise taxes to make up for the lost federal revenue. It's a pretty good bet to assume they're not going to do number three. They're not going to raise taxes very much to make up for this money. So that means they're either going to have to cut benefits or limit eligibility. Now, the thing to keep in mind is that states are required by federal law to provide long-term care to people in nursing homes. That is a mandate. They're not required to provide home and community-based services. That's optional. Every state does it. They do it through a waiver with the federal government, but they don't have to. And I fear, and a lot of people fear, that what's going to happen here is given the choice between where to make cuts when they lose this federal contribution, the first thing to go is going to be home and community-based services. The second thing to go could be payments to nursing homes. They have to provide the nursing home care, but there's no law that says how much they have to pay the nursing home. So you could see an environment where they actually reduce payments to nursing homes, make it more difficult for nursing homes to provide, to have the resources they need to provide good care, and care gets much worse for nursing home residents and patients. Uh, Medicaid HCBS is at real risk. But there is a small change in the new law that actually could, at least in theory, expand Medicaid home and community-based services. Right now, the law says that a state cannot provide HCBS under Medicaid unless the recipient would be living in a nursing home or other institutional setting. In other words, this would be an alternative to nursing home care. The bill actually gives states more flexibility to provide home-based care for people who don't need an institutional level of care as long as they don't increase waiting lists for community care to do so. That's a good thing. The problem is how they're going to pay for it. The bill does include a small amount of money for states to implement the expansion, but given the big cuts in federal payments that we just talked about, it seems improbable the states are going to be expanding HCBS anytime soon. So this is a change. It's potentially important, but it's more theoretical than real. And keep in mind, it doesn't take effect until 2028 either. Um, Another big change in the law is that it effectively repeals that Biden administration rule that would have required nursing homes to maintain minimum levels of staffing, including 24/7 RNs on site. You probably remember that industry groups sued to block the rule. They got a federal judge to actually halt it. The bill that Congress just passed basically repeals that law until 2034. So effectively, it's gone. At the same time, the budget bill increases spending by more than $100 billion for border security and the Trump administration's efforts to deport immigrants. I'll talk about this a little bit more in a few minutes, but the bottom line here is Trump's mass deportations are going to make the existing shortage of medical and direct care workers much worse, which is going to increase costs for facilities and increase costs for families. Another change I want to mention just very briefly from the big budget bill is the increased senior deduction. This deduction, tax deduction, increases deductions for seniors by $6,000. When you add up all the other deductions that seniors could take, a couple over age 65 can take a deduction up to $46,700. That deduction is available only through 2028. And keep in mind, it is not, I'll repeat, it is not President Trump's campaign promise to exempt Social Security benefits from tax. That's not what this does. This simply provides a deduction that they can take against all income, including their Social Security benefits, but is not a direct cut in taxes on Social Security benefits. And for those of you who saw that email from the Social Security Administration, it does not repeal the tax on Social Security benefits for 90% of recipients. Simply not true. I also want to mention on the tax side, one other change that didn't get made. During the campaign, the president talked about a caregiver tax credit. Now, he never said how big the credit was going to be. He never said who would get it, but he did promise a caregiver tax credit. Never happened. He never talked about it after he was elected president. Congress never showed any interest in it. It's not there. Let me now go to Medicare. Um, Again, during the campaign, the president repeatedly promised he wouldn't touch Medicare. That turned out to be not true. The administration is framing its actions on Medicare seemingly to achieve three separate goals. One of them is to reduce fraud, one is to increase efficiency, and a third is to refocus care on disease prevention. They may accomplish some of these things, but at the same time, other changes are going to increase costs to providers and to Medicare recipients and limit access to care. So here are just some of the initiatives that the president has quietly begun to adopt, mostly not through legislation. This is mostly being done through regulations and guidance. So the biggest change, a really striking one, is the administration is going to require for the first time prior authorization under original Medicare, under traditional fee-for-service Medicare. So you've probably all heard Medicare Advantage has been coming under enormous amount of criticism for the prior authorization that it requires. Some of that criticism from the Trump administration. But notwithstanding that, the Centers for Medicaid and Medicaid Services, CMS, is now going to begin requiring prior authorization for certain procedures under traditional Medicare. Now, this is going to happen in the six-state demonstration project, and it's going to apply to 17 different treatments and procedures. The states are New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington. And the procedures include certain back surgeries, steroid shots for pain, some knee arthroscopies for osteoarthritis, and certain artificial skin grafts. CMS says that all of these procedures are vulnerable to fraud, waste, and abuse. The skin substitute story is an especially interesting one. The Biden administration actually attempted to crack down on overuse of this product. Trump, during the campaign, opposed that move, and in March, he actually reversed the Biden rules. Now he's reversed course again, and his administration is going to require prior authorization before Medicare pays for that artificial skin. The other thing to know is CMS says it's going to use AI for these prior authorizations, although it claims that a human will eventually review all of the decisions. Another change in Medicare is what's happening with nursing homes. This is the post-acute and rehab side, the skilled nursing facilities. CMS has proposed increasing the SNF payment for 2026 by 2.8%. The industry says that's not nearly enough. But again, they get a break because the budget bill effectively repealed minimum staffing rules. The other thing that Trump has done is issued an executive order way back in January that calls for substantial deregulation of nursing homes and other Medicare providers. So you can look for CMS to roll back some of the Biden rules on ownership transparency and on quality and safety reporting. Now, the nursing homes are complaining about a 2.8% increase in payments. CMS has also proposed cutting home health payments by 6.4% in 2026. That's more than $1 billion. These cuts have generated, as you might expect, an enormous amount of opposition from the home health agencies, and even from members of Congress, and even from some Republican members of Congress. So we'll see whether or not that change actually sticks. The other thing that they've done for home care is the Labor Department has reversed an Obama era rule that would have required states to pay at least the federal minimum wage for home care workers and also requiring to pay them overtime. Those laws have now been, that regulation have now been repealed. So states, depending on what the state law is, but home care agencies can now pay less than the federal minimum wage of $7.25 an hour, and the workers are exempt from federal overtime rules. Um, there are also some changes that were made again in the big beautiful bill on Medicare savings programs. These are programs that allow very low income people to get extra benefits and even some free services under Medicare. Uh, the Biden administration had changed the rules to make it much easier for them to enroll in these Medicare savings plans, and also in a related program called low income savings programs. Most of those Biden era rules that would have made it easier to enroll are now gone. Uh, Again, starting next year, they're going to be delayed until 2034, so they're effectively repealed. Another set of changes that the Trump people want to make is doing more to encourage doctors and health systems to get away from volume-based payments and do more towards payments for good outcomes rather than the number of procedures they do. Sometimes you hear this referred to as value-based care. Um, there's a lot of it that's been happening. The Trump administration is actually very enthusiastic about it, so you're going to see more of it. They're going to increase penalties and rewards for doctors, nursing homes, home health agencies, physical therapists, and everybody else who provides benefits under Medicare. Another area where they're making some interesting changes is in care navigation services. The biggest change is in a program called Guide. This was a program that was enacted by the Biden administration and has actually just begun to take effect. And what it says is for the first time, Medicare will pay doctors and health systems an extra amount of money every month for providing care navigation and family caregiver supports to people with dementia. Uh, this is a huge change. Um, Providers began enrolling in this last year, and just in July, the program actually began providing benefits to folks with dementia and their family members. Too soon to know how that's going to go, but potentially a real game changer. Interestingly enough, the Trump people, this is one of the Biden proposals the Trump people actually like. And they have said to me that they want to continue this program, but they want to continue it with a big change. That is that under the current law, the way it works now is providers get an additional $200 or $300 a month for providing this extra care. There's no penalty if the program doesn't work. What Trump wants to do is create a penalty if these guide services do not improve the quality of care or save the government money. We haven't seen exactly how it's going to work yet, but it's going to be interesting to watch. The other thing that the administration is keeping from the Biden administration is Biden began providing Medicare billing codes for care navigation. So separate from the guide program, providers actually can bill for providing some additional supports for family caregivers. They're not doing a lot of it yet, but they may, and the Trump administration again is continuing what the Biden administration started. Let me go on to drug prices. Interesting set of changes there as well. You all remember that Biden administration enacted drug negotiations for the first time, and about 10 drugs actually were subject to negotiations. Starting next year, another 10 drugs are going to be subject to negotiations. These are very expensive, very commonly used drugs. Well, the Trump administration wants to control drug prices too, but in a different way. Uh, he favors what he calls most favored nation drug pricing. And the idea is he wants to pressure foreign countries to raise their drug prices while at the same time forcing U.S. drug makers to lower their prices to below the foreign prices. He's issued an executive order to do this, but so far there isn't an actual plan. Exactly how the president would force foreign countries to raise their prices for medications, I don't really know. But this is what he says he wants to do. Whether this is going to supplement the Biden drug price negotiation plan or replace it, again, we don't know, but it's certainly something to watch. Another area where the Trump people say they're going to crack down on waste, fraud, and abuse is hospice care. Dr. Oz, the head of CMS, claims there's widespread abuse in hospice, widespread fraud in hospice, and he wants to crack down on it. Again, we don't know exactly what he has in mind. There are issues with the hospice payment system. It would actually be nice to see some reforms there, but whether these are going to be real productive reforms or something else, we don't know. Um, I want to go back to two other issues or just talk briefly about two other issues that are not directly related to Medicare and Medicaid or older adults, but they have a tremendous indirect impact. So one of them, as I said, is immigration. Uh, this is going to inevitably drive up costs as direct care workers who already are in short supply now become in even shorter supply. I have heard stories, you may have heard stories as well, from home care agencies, from nursing home and assisted living operators who are telling me that a lot of their workers are not even showing up for work. There may be a raid, an ICE raid in their community, and they're terrified and they don't come to work. I've had operators tell me that they've lost 10 or 15% of their staff because their staff has been deported or has been threatened to be deported. Even if you have a green card, the rules have changed and you may not be able to actually work and you may be deported. The immigration rules also have another effect that people may not have considered, but potentially could be very important. And that is the decline in the number of construction workers. So if senior living is thinking about doing an expansion or building a new building or opening a new campus, that's going to be a lot more expensive than it used to be. The other thing that's happening in the Trump administration that's going to make a lot of uh, senior services more expensive are the tariffs. Those tariffs, again, are going to affect senior services because they're going to raise the price of construction, raise the cost of steel, raise the cost of lumber. I've talked to some operators who have canceled projects because they no longer penciled out because the cost of construction is now too expensive. Another place where the tariffs potentially could be extremely important are the cost of drugs. More than 40% of branded drugs and their ingredients are imported from the European Union, where Trump has just imposed big new tariffs. Nearly 90% of generic drugs and their ingredients are imported from overseas, with most from India, where Trump has just imposed a 50% tariff. There is going to inevitably be increases in drug prices because of these tariffs. And that's also going to drive up premiums for Medicare Part D drug insurance. This also applies to medical equipment. The U.S. in 2022, which is the last year for which we have data, imported more than $300 billion in medical equipment from overseas, mostly from China, Germany, and Switzerland, all subject to big new tariffs. Going to raise those prices. So if you need an MRI or an X-ray or something like that, prices are going to go up. Before I wrap up, I want to talk about a couple of other issues that, again, are not Medicare or Medicaid, but are very important for senior services. One of them is the Older Americans Act and the Administration for Community Living. So the Older Americans Act, as I'm sure most of you know, is the umbrella law that covers programs, everything from the area agencies on aging to Meals on Wheels to falls prevention. All of that is covered under this big umbrella law. That law needs to be reauthorized. It was supposed to have been reauthorized last year. It wasn't. So it's kind of hanging out there in legislative limbo. Nobody knows what's going to happen to it. It also needs money appropriated to operate the programs. President Trump has proposed in his 2026 budget, separate from the budget bill that just passed, in his 2026 budget, he's proposed freezing federal funding for all those programs. Congress is now in the process of considering that budget. We'll see what happens. My fear is that some of that funding is going to get cut. Um, but even if it's frozen, it's insufficient to provide the care that people need. The other very important issue around the Older Americans Act is it's operated by a very small federal agency called the Administration for Community Living. The Trump administration proposed abolishing the Administration for Community Living back in the spring, and it proposed, and actually did, fire about 43% of its staff. Now, because of lawsuits and other things, that staff came back for a while. Now they've been fired again. One of the big challenges here is many of the people who are gone were the grants managers and the budget people. So imagine that you're a community-based organization that runs a Meals on Wheels program, and that program needs to be renewed. The grant needs to be renewed. The problem is that at the moment, there's nobody at the other end of the phone to answer your call to get the program renewed. There's nobody to review the paperwork. So this is kind of a backdoor way for the administration to eliminate or at least drag its feet on funding for a lot of the programs under the Older Americans Act. We don't know what's going to happen now. The Administration for Community Living is supposed to be folded into another office at the Department of Health and Human Services. That hasn't really happened yet. Nobody knows quite what's going to happen. But again, it's going to create a lot of disruption. Already has. It's going to create a little bit more. And finally, let me just mention senior housing. Senior housing is funded largely through programs at the Department of Housing and Urban Development. One is called the Section 202 program, one is the Section 8 program. What the Trump administration's 2026 budget proposed is to cut funding for all of the rental subsidy programs, including those, by about 40%, and to turn it into a block grant. Basically, turn all of the remaining funds over to the states and let the states fight over who gets the money. So realistically, what's going to happen here is there would be demands by families, young families with kids for subsidized housing, and demands by older adults for subsidized housing. I don't know about you, but I think I know who's going to win that fight, and it's not the older adults. Now, Congress has already given some indication that it's not going to do all that. Um, it seems reluctant to make the big funding cuts. And it also seems to want to give states more flexibility than they have to operate these programs, but not turn it into a straight block grant program. Again, we'll see what happens to the budget. That's going to be a debate that's going to go on through most of the fall. We'll see where it goes. But again, the rental assistance programs for older adults are in some jeopardy. So I'm going to stop there. I'm going to take another drink of water, and then I'm going to happy to answer any questions you've all got.
All right. Well, that was a great overview, um, Howard. And I see we've got lots of questions and comments. So let's, and that's perfect timing. So we've got about 30 minutes, folks, that we can go through these. Um, let's see. Okay, Steve says, what chance is there of having enough nursing home beds to accommodate those who formerly had home-based care? Um, any thoughts on that?
Yeah, so this is going to be a real challenge. Um, I think it's going to depend on where you are. I think there are some estimates. Brown University did a study and they estimated that about 500 nursing homes would probably have to close because of the Medicaid changes. Um, a lot of this is going to depend though on geography. There's some places that are overbedded that probably already have too many nursing home beds, um, and they'll probably be fine. There are others, particularly rural areas, where there may not be a nursing home within 50 or 100 miles. Um, so it's going to be a big deal. Um, the other issue is, will these people even move into nursing homes? There's so much resistance, so much reluctance. People may not do it. They may just decide, I'm going to just stay home and I'm going to do what I can do. And the outcome of that could be pretty tragic. We'll see how it goes.
Okay. Um, let's see. Larry says, can the next Congress change these or the law? And Howard, like, you're sort of in the inside politics of the midterm elections, and if the House and the Senate change, what are your thoughts on this?
So, Congress, if the Democrats could win the House and the Senate, which they got a better chance to win the House than they do with the Senate, we'll see. Uh, they could try to change the law, but the president would veto any changes. And there's not remotely a chance that there would be a veto-proof majority of the Democrats in the House and Senate. So essentially, if the Democrats controlled one of the houses of Congress, they could prevent things from getting much worse legislatively, but not much chance they can make things better. So I think we're going to have to see what happens until 2028. The one exception, as I mentioned before, is this Medicaid provider tax, where you are seeing Republicans, Senator Josh Hawley, a very conservative Republican from Missouri, um, who said he was against increasing the provider tax, but then voted for it. A couple of days after he voted for it, he says he wants to repeal it. So that one is an open question. Uh, the others, I think there's probably very little chance they're going to change until after 2028.
Okay, great. Um, let's see here. Steve says the minimum staffing requirement was, in my opinion, the best thing that Biden did. And I've heard a lot of that about that legislation and
So yeah, so the minimum staffing rule, we could probably do a whole show on that. I have some doubts about that, um, because I think staffing is more a symptom of a badly operated nursing home than it is a cause of a badly operated nursing home. But nonetheless, Biden proposed this was a regulation. This is not a statute. Congress didn't do this. This is just done by regulation. And there's just no chance it's going to happen. As I said, what the law does is technically it defers the regulation until 2034, 10 years from now or 9 years from now. Um, but essentially, it's dead. Um, the other issue, when you go back to the immigration stuff, is I'm not sure that given the shortage of direct care workers, that many nursing homes could have complied with the minimum staffing rule, even if it took effect. Wouldn't have surprised me at all to see the Biden people delay the effective date of that because it's so challenging for people to find staff.
Mhm. And let's hope that the industry, like they do in many industries, is self-regulate before government needs to come in and make laws in that area.
Steve, I recently gave a talk to a group of operators about exactly this topic, and I could not agree with you more. If the federal government deregulates, it's going to open the door for the bad actors to be even worse.
Mhm.
And I said to this group of providers, you all know who the bad actors are. You know better than I do who they are. And they're destroying the reputation of your industry, and it's up to you to do something about it. And you're exactly right. They're going to have to find a way to self-regulate. The other thing that's going to happen is in the absence of federal regulation, you're going to see all this different state regulation. So if you're an operator who operates in different jurisdictions, so Steve, you live in Virginia, I live in Maryland, you may have an operator here who has facilities in Maryland, DC, and Virginia. They all operate under different rules. And those rules are going to be even more different as you get different states responding to the federal deregulation. So in some ways, it's going to make things more complicated for operators.
Okay. Now, Rena asks, what are the tax deductions that older adults can take? But is there anything new or is there anything going off the table that might be related to a tax deduction for older adults?
Not really. I mean, there were a bunch of things that were on the table, but they never really happened. So really the big change, the one big change is this senior deduction. And with the ability of an older couple to take a standard deduction of more than $47,000, there's going to be very few seniors who are going to be itemizing. Most of them are just going to take the standard deduction and move on. Um, so I think actually what this is going to do is it's going to discourage people from itemizing, and more are just going to feel it's in their interest to not bother to do the paperwork. They'll just take the standard deduction.
Okay. Let's see. Parnell says, so for me to be clear and understand, you state MSP is gone in 2026, but we can revisit it in 2034. And just remind me again, what's MSP?
So it's a Medicare savings plan. It's not gone.
Got
Let me be clear about it. It isn't gone. The program is still there. Hasn't been repealed. What's changed is the Biden administration made it very easy. In fact, it created automatic enrollment for some of these subsidized Medicare programs. That's what's gone. It's going to require now more paperwork for people who are eligible to enroll in these programs. The programs are still there, but it's going to require a lot of support for low-income people to get enrolled. That's the big change that was made.
Okay, and that's, I think, one of the main things that I've been hearing in the news is that it's just going to be more difficult to access programs.
That's right. What,
Yep.
what what
Okay.
they're doing is it's kind of a funny thing. I mean, the Republican, not to be partisan about it, but the Republican brand used to be deregulation and getting rid of government red tape. What they're doing with this law is they're creating more red tape. but not for businesses. They're creating red tape for individuals, particularly for low-income individuals. And a lot of people who absolutely are eligible, totally qualify for government benefits aren't going to get them because they're going to mess up the paperwork. The other thing to keep in mind is there's going to have to be somebody at the other end to read the paperwork. That's going to require more employees at the state level or at the federal level. And we're in an environment where we're reducing employees. So that's going to mean that it's going to take more time for people to review the documents, and it's going to delay enrollment and it's going to delay eligibility.
Okay, I like Barbara's question is, would you suggest some factual and reliable websites, newsletters, and other sources to keep up on this type of information? Um, yeah, how do we become Howard Gleckman? How do we stay informed like you?
So, shameless plug here. I do this regular column, and you can read it on Forbes.com, or you can also read it on my own website, which is howardgleckman.com.
And I'm
Uh,
dropping that into chat, folks.
so it's all there, and I write about this stuff pretty much every week, so you can find it there. NCOA, National Council on Aging, does a pretty good job of keeping up with this stuff. Um, Family Caregiver Alliance is another group that does. There are other folks who are ARP kind of does, not as good as I wish they would, but so there are some places to go where you can get some, I think, a pretty good summary of what's happening.
Okay, great. Okay, all right. Uh, okay. Gina says Trump never speaks about SSDI, which is what I'm getting, and not 65 yet. Social Security disability income. So will I qualify for the tax savings, or only my husband who is over 65 years old?
Yeah, it's a really good question. It's an important point. So the special senior deduction applies only to people 65 and older. So if you're on disability and you're under 65, you're not eligible. If you took your Social Security benefits at 62 or 63 or 64, you're not eligible. You're only eligible once you turn 65. So this is only this in again, they create a lot of confusion about this. There's no connection, no direct connection between the senior deduction and Social Security. The senior deduction is only uh, dependent on your age, whether you're taking Social Security or not. Let's say you're 69 and you haven't yet enrolled in Social Security, not yet taking Social Security benefits because you're still working, you want to wait until you're 70, you can still take the senior deduction. It's completely disconnected from Social Security. The Trump administration, unfortunately, has created a lot of confusion about this, but don't be fooled. There's nothing to do with Social Security.
Okay. Okay. Ken says the medical community suggests that the number of primary care providers accepting Medicare will continue to decline even as demand will increase. Do you agree with this?
The particularly primary care docs, we're just losing primary care docs hand over fist. Whether they take Medicare or Medicaid or they just take commercial insurance or they don't take anything, we don't have nearly enough primary care docs. We especially don't have nearly enough people who specialize in geriatrics.
Hmm.
And that problem is just going to continue. I think most docs are going to continue to take Medicare because it's kind of how they get paid. I worry more about Medicaid. Uh, I think more and more doctors are not taking Medicaid. That's becoming a bigger challenge. Um, I think we're going to have to get used to, and this could be another show too, we're going to have to get used to using uh, nurse practitioners and physicians' assistants who are going to pick up a lot of the gap. I talked to somebody who runs a very big uh, integrated health system a few weeks ago, who was telling me that they are trying to change expectations of their patients so their patients do not expect to see their doctor every time they have a visit. They're going to come to a practice and they're going to see whoever can see them. It may be another physician, it may be an NP, it may be a PA, it's going to be whoever there is. And he said, he's going to get pushback from this, but he's got no choice. The only way he can make the numbers work is to use.
Well, and also I think it is important to manage people's expectations because a lot of us are under the assumption that, I developed this relationship with one doctor and he knows about my kids and all that. And, you know, it's just not the reality in this day and time.
That's exactly right. And I saw a couple of people on the chat talking about, don't denigrate NPs and PAs. I absolutely do not. They do
Oh,
terrific.
I think they're the doctors. They're basically our doctors of the future,
Yeah, and they
the
can
way
do
we.
they can do, 99%. Maybe you've got something that's really complicated and you need to see a physician. But for the most part, for routine stuff, there's no reason why a physician's assistant or nurse practitioner can't do it just as well as we
Now,
do.
let's see. Barbara says, "What states are best for older Americans on Medicare to live?" And Howard, when I saw that, I dropped it into AI. But I'm kind of curious. Do you happen to know uh, offhand states that are doing things really exceptionally?
You know, um, no, I don't. I mean, there are a number of organizations out there that rate states. ARP does a regular project that rates states for older adults. But so much of this, I mean, some of this has to do with healthcare, some of it has to do with cost of living, some of it has to do with climate. I mean, there's a million things that is so I wouldn't even try. Above my pay
Yeah,
grade.
and like when I dropped it into an AI chatbot, it ranked Kentucky as number one, excels in Medicare accessibility, low cost, high quality, certified hospice and home care, and low home care costs. So I think one of the things when I look at this brief list that popped up, there are some more rural states that may have lower costs than some of the more densely populated
But
regions.
but keep in mind, having said I'm not going to get into this now, I will. Keep in mind that rural areas may have lower costs, but you may have poor access.
And not as many providers.
Exactly. So there may
Yeah.
not be a doc who can take care of you. The hospital may be 100 miles away. Nursing home may be 100 miles away. So you got to keep that in mind. People who say they want to retire to, some, beautiful house in rural Maine, it's great up there, but you may be hard to find a doctor.
Okay. Oh, this is a good one. Kelly asks, is there any indication that large organizations like AARP are organizing and fighting around these changes? Have you stumbled into any factions that seem to be opposing these changes that we can support or people can connect with?
So one of the really interesting things about what happened with the big budget bill was for the first time in my memory, the disability community and the aging community actually got together to fight against some of these changes. There's always been this tension between the two communities. And they're actually able to pull together and do some things. Um, you know, I know there's some people on here who are connected to ARP. I will say that the problem with ARP is it is big and it is slow, and it takes a long time for it to go through its sort of internal bureaucratic management changes to respond, and things, especially when things happen as fast as they did in the early days of the Trump administration. So I think there are other organizations that were more nimble and were able to advocate more effectively for change than the national ARP did. I will say that state ARP chapters do a very good job in terms of advocating on state law. They have a little more flexibility. They can be a little more nimble. So I think it's a little bit of a complicated story.
Okay. All right. But there's no like Center for Medicare Advocacy or like a group that is um that you've seen that's really uh making an effort to
Yeah,
fight these things.
yeah, no, I think there are a bunch. I think there are a lot of groups that are doing a good job. But they're all small. They can do, little slices of things. I think it's a matter of kind of building these sort of coalitions. And,
Hmm.
one of the things I always say to people is the most important thing you can do as individuals is talk to your local legislator, talk to your local congressman about what your life is like, or maybe for many of the people watching this, what your clients' lives are like. Because trust me, they don't know unless they've lived through it themselves. They have no clue. And you don't even have to ask for anything. You should just say, and again, I'll go back to my caregiving experiences, what it's like to be trying to hold down a job and the phone rings and you see the number the phone call comes from and you jump out of your skin because you know it's something really bad just happened.
Hmm.
And explain that to a member of Congress. Explain how if you're a 50 something woman, you're trying to take care of your kids and you're trying to take care of mom and you're trying to hold down a job and you can't do it all.
Yeah, no, the storytelling is really powerful. Okay, I'm looking at the clock. Can you hang on for maybe 5 minutes after the
Sure,
hour?
absolutely. No
Okay,
problem.
cool. Well, folks, we'll try to get as many of these questions, but I like Katie's question. She said, Howard, are you available for consultations with nonprofits or organizations navigating these changes, or do you have a recommendation to turn to? And folks, if your organization is in the middle of all this, Howard does some select consulting, and I'll make sure to have his contact info there. The other thing is, you can see what a great speaker he is. If you're associated with, a conference, or you need a keynote or something like that, Howard does an amazing job of those presentations. I'm feel fortunate to have him on here. But did you want to add anything to that?
No, I am available for consultation. I'm happy to help out organizations. There's a fee, but I'm happy to help out organizations. So sure.
And I'll drop his contact. It'll be on the recording link at proaging.com, folks. Elva says, how can workers be paid less than minimum wage? Servers get tips, which is why many states, including Texas where I live, pays less than minimum wage, but CNAs and other workers don't receive tips. So how is that even legal? It- it- and I guess this is also an umbrella of the problem in senior living of wages and benefits and things of that.
Yeah, it's a really bad situation. And they operate under special rules, and the rules are really bad. And it's one of the reasons why it's so hard to find care workers. It's difficult work, it's dangerous work. Uh, I always remind people it's more dangerous to be a direct care worker than it is to be a coal miner because of the back injuries that they suffer. Uh, so it gets really complicated because a lot of them are not working full time; they're only part-time workers, and they're subject to different rules.
Okay. And Elva asked about the 6 states that are doing the demonstration. I copied it into chat: New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington.
Correct.
Um, and let's see. Okay. This is Jose has an AI question. Howard and I were talking about AI. Can AI agents working as assistants to caregivers help alleviate the staffing crisis? Um, your thought on that, but also, Howard, we were talking previously about what the government is playing around with in terms of authorization and rumblings of utilizing AI as a way to expedite approvals and things like that.
Yeah, so you know, I'm not a big fan of AI and robots and all that stuff doing direct care work. I don't see that anytime soon. They certainly can make things more efficient, kind of in the back office and in terms of, managing paperwork and that sort of thing. I think there's certainly going to be an opportunity, especially when AI gets a little better than it is, to do some of that. There certainly are opportunities for artificial intelligence in diagnostics in medicine. There have already been some interesting experiments that show that AI can do a better job than physicians in diagnosing some conditions. So I think there's going to be a role there. Um, when you think about things like I was mentioning, prior authorization, the Medicare Advantage plans already use AI for prior authorization, and it's not very popular. Um, we'll see what Medicare does. They're going to presumably hire some consultants to do this, and we'll see how it goes. But at this point, too soon to tell.
Okay. Let's see. Okay. Yes, you will have chat at proaging.com, folks. Couple of questions about that. Um, okay. Tricia says, can Howard talk to what I've heard about citizens being forced to opt for Medicare Advantage plans in the next few years? Traditional Medicare may no longer be an option.
So you all may remember Project 2025. This was the conservative manifesto that came out during the campaign. Trump claimed that he didn't know anything about it, but the reality is, if you look at what the president is doing, a lot of it is following the Project 2025 playbook. Project 2025 said explicitly they wanted to make Medicare Advantage the default option in Medicare. So they wouldn't get rid of traditional Medicare, but essentially what happened is when you enrolled, you would be enrolled in Medicare Advantage unless you chose not to be. Uh, that hasn't happened yet. Um, there's been no proposal for the administration to make Medicare Advantage the default. And in fact, the administration has actually taken some steps to crack down on what it sees as abuses in Medicare Advantage. So it, there's kind of this sort of inconsistency with the Trump administration and Medicare Advantage. They like it, they like the idea of managed care, but on the other hand, they realize that it's not working the way they wish it would. So we're going to have to see. But so far, traditional Medicare is still available to anybody who wants it. And there is no requirement that you have to opt out of Medicare Advantage. That hasn't happened yet. May happen someday, but not now.
Okay. All right. I know we're overstaying our welcome with you, and I want to make sure that I can always get you back on when I beg real nice. But let me just do a quick okay. Uh Sally Ann says, has there been any changes for single spouses or vets or anything like that on the horizon that you've heard about?
Nothing I've seen in the bill for veterans. I mean, the biggest challenge there is the big cuts to the VA. And the VA, as some of your viewers may know, has some very creative programs for older adults. And I worry with the cuts in Veterans Administration staffing, whether or not those programs are going to survive, but I just don't know.
And Barbara would like you to say something about Medicare Advantage. Do you recommend this for 60, 70, and 80-year olds? Like, what are your thoughts on Medicare Advantage? And there's a few folks that have said that they've heard rumors that the Medicare Advantage benefits are going to be shrinking.
They are going to be shrinking. So if you look at the finances of the big insurance companies that are running Medicare Advantage, United Health, Aetna, some of the big players, Humana, they're having financial problems. The Trump administration is talking about giving them smaller increases in payments. Where they're likely to make reductions are in what they call the supplemental benefits. Those are the silver sneakers and the gym, the gym memberships and the hearing and the vision and all that. You may start seeing some reductions or some limitations in your ability to use those. So do I recommend Medicare Advantage? This is such a personal choice. I can't say one is better than the other. Some plans are better than the other. You certainly can look and see online reviews and see which plans are better than others. Uh, but it really depends. I mean, Medicare Advantage is significantly less expensive in terms of premiums than traditional Medicare, Medicare Part D, Medicare Supplemental. By the time you add all that up, it's a lot cheaper to get Medicare Advantage in terms of the premiums. In terms of the care you get, in terms of the overall costs you incur, it depends. It depends on the plan. It depends on your health status. The other thing I
Your
tell
prescriptions, a
your
lot is on your
prescriptions,
prescriptions.
totally. The other thing I'll just very briefly say to people is if you enroll in Medicare Advantage, it's very, very difficult to get out of Medicare Advantage and get back into traditional Medicare. Because if you do, and you want to buy a Medicare supplemental policy or a Medigap policy, the Medigap insurers can underwrite you. So if you have pre-existing conditions, it may be impossible or very expensive for you to switch from Medicare Advantage to original Medicare plus Medicare supplement. So if you get into Medicare Advantage, you can switch among Medicare Advantage plans, but be careful, you may not be able to get back into traditional Medicare.
Something that I've heard a little bit about, and Ellen is asks, please respond to whether telehealth will still be covered under Medicare. I know the pandemic had a lot of shifting to telehealth, and is that in our culture permanently now, or are they going to be cutting some of the telehealth
Well,
benefits?
I never say permanently, but so the deal was that there was a temporary federal law that allowed Medicare to pay for telehealth. That law was supposed to expire last year. It actually got extended. So at least for now, Medicare will continue to pay for telehealth. Docs increasingly are using it. They're learning to like it. A lot of patients I know are using it for routine stuff. They like it. So I think it's something that's got some staying power. Absolutely.
Okay. All right. I think we've done a pretty darn good job of getting through most of the questions. I apologize, folks, if you typed something in there and we didn't get to it, but I think you really did the very thorough overview, Howard. I mean, your knowledge on this topic is amazing, and there's it, and I you could we could give the same talk next week, and there's probably going to be changes, right?
You're probably right. And Steve, I want to say, one of the reasons why I love to do this is your audience is great. I mean, I'm looking at there are over 100 questions in the chat. I mean,
It's mind blowing, isn't it?
it
And
really is. And the worst thing
yeah,
for me as a speaker is to talk to an audience and get no response. And
it's
I'm getting a great response. It's terrific.
it's why I really get charged up to have these discussions. Even, I mean, this discussion, we had close to 400 people that signed up, but even when I have 40 people, like we have never done a discussion without a handful of questions. And folks, you guys come up with questions that I could have never have come up with as an interviewer. And that's what I love about it because these are real life stories. This is what a politician needs to drop in on is to hear this concern firsthand and understand sort of the pulse of our country related to this.
Absolutely. Well, again,
Um,
thank you. This has been terrific.
yeah. And folks, remember, I'm going to give you Howard's contact info, his Forbes website, his website. Uh, if your organization needs his expertise, he can be hired as a consultant. He could be hired as a keynote speaker for a conference coming up. And then I'm just and I hope some of you hire him so that he keeps on coming back on my discussions. um, Howard, this has been a great another great presentation. I will work on getting this up online as quickly as possible. And until the next public policy crisis, I hope you do. I hope you have a good day and a good week or what have you.
Thanks a lot. Always a pleasure to do it. And